Lyme disease is a tick-borne illness that is typically caused by Borrelia burgdorferi. It is spread through the bite of the Ixodes scapularis, which is pictured here. There are 3 classical stages of Lyme disease. However, less is documented about atypical presentations. Here I will discuss an atypical presentation which involved vague bilateral ear pain, a remote history of Bell's palsy, and waxing and waning cutaneous symptoms. Our case involves a female in her 30s who presented to the clinic for evaluation of bilateral ear pain for 3 months. 1 month prior, she was prescribed an unknown antibiotic and intranasal fluticasone without any benefit. She complained of a waxing and waning skin rash that she thought was similar to hives. She did note that she swam often. She denied any history of seasonal allergies. On exam, a moderate left ear effusion was noted. The rest of the exam was normal, including absence of any visible rash. The initial plan was to continue intranasal fluticasone and start loratadine. 1 month later, the bilateral ear pain was still present. There was minimal relief provided from our initial treatment. Upon discussing with her further, she stated that the cutaneous symptoms began 1 year ago. There was a history of tick bite around that time. Additionally, a few months prior to this visit, she notes Bell's palsy. A referral to ENT was made due to the persistent bilateral ear pain. Due to an increased positive Lyme testing in the area, along with a more complete history of Bell's palsy, cutaneous symptoms, and a tick bite, Lyme disease modified 2-tier testing was ordered. The total antibody, IgG, and IgM were all positive. With these results, she was prescribed doxycycline for 28 days. 16 days later, she came back complaining of joint pain, decreased mobility, joint tenderness, joint locking, and joint spasms. She was diagnosed with Yarish-Herxheimer reaction. The joint pain persisted, and she was seen and treated regularly with OMT, which provided some improvement. 4 months after the initial encounter, she complained that she was having frequent ear infections, facial twitching, ear pressure, joint pain, and twice-weekly rashes. A repeat dose of doxycycline twice daily for 28 days was prescribed. A Lyme PCR was ordered. The PCR returned with a negative result. At a follow-up near the end of her second course of doxycycline, she reported that the joint pain was improving, but she was still having itching and fatigue. She was given topical Benadryl for symptomatic relief. She was subsequently lost to follow-up. It is estimated that the specificity of 2-tier testing is higher than 97%. Thus, it's felt likely that the test results for our patient were true positives. Oral doxycycline for 10 days is the recommended treatment for localized Lyme disease. Initially, our patient was given a 28-day course, which may be over-treatment. Then, a treatment with 28 days was repeated for suspected Lyme arthritis, which is in accordance with the current guidelines for Lyme arthritis. A Yarish-Herxheimer reaction typically occurs within 2 hours of treatment and resolves within 24 hours. Thus, it is felt that our patient was misdiagnosed with a Yarish-Herxheimer reaction. There was an inadequate response to treatment, but some of her residual symptoms had a positive response to OMT. Overall, this case illustrates the importance of early diagnosis and the appropriate treatment to prevent post-treatment Lyme disease syndrome. It highlights the necessity of differentiating between persistent symptoms, Lyme arthritis, and Yarish-Herxheimer reaction. It suggests that the primary care practitioner should have a low threshold to test for Lyme disease in locations where it is likely to occur and in the right clinical setting. Overall recommendations include to use modified 2-tier testing for diagnosis, then follow clinically. Do not repeat any testing to judge how well the patient is responding to treatment, including ordering PCR. Treat localized disease with 10 days of doxycycline. Consider infectious disease referral if there is an inadequate response to initial treatment. Consider adjunct therapies such as OMT for post-treatment Lyme disease syndrome.